Hi everyone. So this is the third video in context to the orthopedic images, and the image shown here is of Powell's classification. Powell's classification of neck femur fractures. Basically in neck femur fracture we have four classification: Garden, Powell, and anatomical classification, and Linton's classification. So the first one is Powell's classification. In this we determine the angle between the angle of the fracture line. So if it is 30 degree up to 30 degree, then it is type 1. From the horizontal we determine the angle of the fracture line. So if it is up to 30 degree, then it is type 1. In type 2 it is 30 to 50 degree, and in type 3 it is 50 or more. So 30, 30 to 50 and 50 or more. Powell's classification basically linked with the angle. Then we have the garden classification. Garden classification is on the basis whether it is displaced or not displaced. In the garden, D is coming, so it is based on the displacement or not displacement. Garden 1 is incomplete fracture. Garden 2 is complete fracture without displacement. Okay, incomplete and complete. Then in the 3 and 4, we have complete fractures, but partial displacement is 3 and full displacement is 4. Incomplete, complete, partial displacement, full displacement. That is about the Gardens classification. Then next image we have is of the important things which we need to see in relation to the X-ray hip of the bilateral hip, radiological features. So first one we need to see is the Shenton's line. Shenton's line is basically a line formed by inferior border of neck of femur and the superior border of the obturator foramen. Superior border of the obturator foramen and inferior border of the neck of the femur. Then is Hilgen-Renner line. H for Hilgen-Renner and H for horizontal. It is horizontal line through the triradiate cartilage in the green one. In the Perkins line. Perkins is vertical. Remember PV. Perkins is vertical and drawn at the outer border of the acetabulum, and perpendicular to the Hilgen-Renner's line. Then we have the acetabular index. Acetabular index is in relation to the Hilgen-Renner's line, and it is angle formed by junction of H line and the line drawn along acetabular surface. Here we draw a line along the acetabular surface, and the angle formed between H line and the acetabular surface is known as acetabular index. Then next we have the angle of Wilberg. Okay, angle of Wilberg is basically angle between Perkins line and the line drawn from the lateral lip through the passing through the femoral head. So lateral lip and femoral head and the Perkins line is angle of Wilberg, while acetabular surface and the Hilgen-Renner's line is acetabular index. So these are the five important things which we need to remember in relation to the X-ray hip: Shenton's line, acetabular index, Hilgen-Renner's, Perkins, and angle of Wilberg. Then next we have another image. It is showing Shenton's line, Hilgen-Renner's line, and Perkins line. It is important in the developmental dysplasia or congenital dislocation of hip. Then next we have the images of dislocated hip and what will be the deformity. So basically in the anterior dislocation we will have flexion, abduction and external rotation. The leg will be abducted, hip will be abducted and externally rotated. And in the posterior dislocation it will be flexed, adducted and internally rotated. Remember the posture. And next, this is showing the posterior dislocation of the hip. How we will identify an X-ray? See, here the leg bone, that is femur, has gone into internal rotation and adduction. So it is posterior dislocation. While in anterior dislocation, it does not move medially, it has moved laterally, that is external rotation and abduction. So it is anterior dislocation. Then next we have the fishtail deformity. Fishtail deformity is distal humerus contour abnormality when the lateral aspect fails to develop or gets reabsorbed. Basically, it is deformity of the lateral humerus or the trochlea, lateral trochlea. It is relatively avascular. And if the fracture occurs in this case, that is distal humerus, then there will be deformity that is called the fishtail deformity. In the supracondylar humerus fractures. And osteochondrosis of the humeral trochlea is known as Hageman's disease. Hageman's disease. Then next we have the figure showing the ulnar nerve, that is book test for the ulnar nerve. Here the ulnar nerve is not functioning, so adductor pollicis will not be functioning. Adductor pollicis if not working, then the flexor pollicis will compensate for its action. So in the ulnar nerve we have the book test, and this is demonstrated by the flexion of the thumb. Froment sign is also for the ulnar nerve palsy. Here also, if the bending of the thumb occurs, that is compensatory flexion, then ulnar nerve palsy, and if negative, then normal ulnar nerve. Positive froment is ulnar nerve palsy. Then we have special test, Phelan's test and Tinel's test. Phelan's is wrist flexion to maximum for 60 seconds, and here will be pain. Tinel is trapping over the transverse carpal ligament. And if pain, anesthesia, and paresthesia occurs, then it indicates the nerve injuries. Then Durkin's test. Durkin test, also known as carpal compression test. It is for the median nerve. Then is Finkelstein's test. Finkelstein test is for the decurvance tenosynovitis for the first extensor compartment. Means first extensor compartment we have the abductor pollicis and the extensor. Abductor and the extensor pollicis brevis. For that muscles we use tenosynovitis of the tendons. We use Finkelstein test. In this basically the thumb is flexed and the fingers are rotated or flexed over it, and the wrist is moved into ulnar deviation. And if pain and crepitation occurs over the radial styloid, it suggests that the tenosynovitis of the first extensor tendon is there. Then flexor tendon tenosynovitis. What will be the features in the flexor tendon tenosynovitis? That is known as Canavel's cardinal sign. Basically, the tenderness will be there over the tendon sheath. Then there will be finger held in the flexion. Finger will be held in flexion, and if we will be extending it passively, then there will be pain. Flexor tendons are disappeared, then fingers will be in the flexion and they will be fusiform swelling. These are known as Canavel's cardinal signs. Then next we have the Wartenberg syndrome. Wartenberg syndrome, also known as chiralgia paresthetica. It is compression of the superficial branch of the radial nerve. Superficial branch of the radial nerve is involved between the ECRL and the brachioradialis. Extensor carpi radialis longus and the brachioradialis. This is known as chiralgia paresthetica. Then we also have counterparts related to entrapment syndrome like carpal tunnel syndrome. We need to remember in relation to the medial nerve. Then pronator teres syndrome, also in relation to the median nerve, and it is basically beneath the ligament of Struthers, or bicipital aponeurosis, or in relation to pronator teres. Carpal tunnel and pronator teres are for median nerve. Then for ulnar nerve we have the cubital tunnel. Cubital tunnel in relation to the flexor carpi ulnaris or arcade of Struthers, not ligament of Struther but arcade of Struthers, and Guyon's canal, that is for ulnar nerve. And myalgia paresthetica, like this is in the upper limb. In the lower limb we will be having myalgia paresthetica, and that will be due to lateral femoral cutaneous nerve. And in the foot region we will be having tarsal tunnel syndrome for posterior tibial nerve and Morton's metatarsalgia for interdigital nerve compression between the third and the fourth toe. Morton's metatarsalgia. These are not, images are not there. I'm repeating it orally. So please do make notes of it. Then next we have intersection syndrome. Intersection is between the muscle bellies of the first compartment and the second compartment, second and third dorsal compartment. For the first compartment we have the decurvance. Then if in the intersection of the first and second and third is involved, then it is called intersection syndrome. And in the first compartment, we know abductor pollicis and extensor pollicis brevis. Then this is empty can test. Now we are studying the test related to the shoulder joint. So empty can test, also known as Job's test, is for the supraspinatus. In this, basically, both the arms of the patient are raised to the scapular plane. In the scapular plane, and then the patient is instructed to hold his arms like this, that the thumbs will point downward towards the floor, as if person is draining liquid out of a can. And then examiner will apply the downward force, and the patient will have to restrict it. If the patient is not able to restrict it, means the supraspinatus is not working. Then the jerk test. Jerk test is for the posterior instability. Here basically we axially load the humerus proximally, and then the arm is rotated horizontal adduction. Okay, and it is for the posterior instability. Jerk for the posterior instability. And crank test. Crank test is for the labial injuries or slap lesion. Superior labrum from anterior to posterior tears. Basically for the labium, for the labrum, which is in relation to the shoulder joint. For that, crank test is performed. Okay, here the arms are not in the scapular plane, they are elevated. In the jaw or the empty can, it was at the level of the scapular plane, but here the arm is elevated and then axial load is applied. Okay, clicking or catching sensation means positive crank test. Then again, one another test for supraspinatus is drop arm. Okay, either the empty can or the drop arm test. These are for supraspinatus. In drop arm, patient is not able to hold the arms at 90 degrees of abduction, and it will drop to her side. Okay. Then we have sulcus sign. Sulcus sign is for inferior instability. For the posterior instability, we had jerk test. For the inferior instability, we have the sulcus sign, and it is for due to laxity of superior glenohumeral or coracohumeral ligaments. Then next we have the image of scaphoid fracture. Scaphoid fracture, it is a boat-shaped bone and it will be fractured. The important thing which we need to remember in relation to scaphoid fracture is that it is having retrograde blood supply. So more proximal the fracture is, the more chances of avascular necrosis are there. And basically in this we use the glass holding cast. Glass holding cast. How we will remember? Imagine scaphoid as a scotch. So glass of scotch is being held by a patient. Okay. Glass holding cast is applied. Okay. Then we have the supracondylar fracture humerus. Supracondylar. See, here is our ulnar radius and here is humerus, supracondylar fracture humerus. And we have the classification for it, that is Gartland's classification. This is Dunlop and Smith traction. Dunlop and Smith traction is used for supracondylar fracture humerus. Then this is the classical deformity which occurs in the supracondylar fracture, that is cubitus varus. Varus means towards the inside, and it is also known as gun stock deformity. Then this is the needs classification for proximal humerus fractures. It is based on the whether the fracture is displaced in one part, two part or three part. So one is minimal displacement, then two part is anatomical neck, fracture at the anatomical neck. Three part is fracture at the surgical neck. Four part is fracture at the greater tuberosity. Five part is fracture at the lesser tuberosity. And six is fracture dislocation. So one is minimal displacement, two is anatomical neck, then surgical neck, then greater tuberosity, and then lesser tuberosity and fracture dislocation. Six classifications are there. This is again another image showing the proximal humerus fracture in this region, and it is classified on the basis of Neer's classification. Then next we have the image of the shoulder dislocation. Here shown is posterior shoulder dislocation. It will demonstrate classical light bulb sign, also known as empty glenoid. Okay, glenoid cavity is empty and it is seen in epilepsy. Then next we have the terrible triad, Hodgkin's terrible triad. It is basically the three things, triad of three things in the region of elbow. The elbow is dislocated, coronoid coronoid fracture of the ulna and radial head fracture. In the ulna, coronoid fracture, and in the radius, head fracture, and elbow is dislocated. Then this is Colles fracture. Colles fracture is dorsal displacement of the distal segment. Dorsal displacement. And this Smith's fracture is volar displacement. Colles and Smith are basically fracture of the radius, and if the dorsal displacement occurs, then it is Colles fracture, and if the volar displacement or ventral displacement occurs, then it is Smith's fracture. And in Colles fracture, how we will correct it? We will apply traction and counter traction, and then the pronation of the hand will be done, and basically the cast used or the position in which the cast is applied is not the glass holding cast that was for scaphoid. Here is handshake cast, and here will be palmar deviation. Okay. Then this is image showing the Monteggia fracture. For the Monteggia and Galeazzi, remember Murga. Murga. Mu means Monteggia is for ulna. So proximal ulna is fractured and the radial head is dislocated in Monteggia fracture, while in Galeazzi distal radius distal radius is fractured and the distal radioulnar joint is disrupted. Then this image we have is of button ear deformity. For the button ear, remember that the proximal joint, that is the proximal interphalangeal joint, is flexed, while in the swan neck, the distal interphalangeal joint. Remember one joint, okay, which is flexed. The other will be extended. So in the button ear, proximal flexed, and in the swan neck, distal is flexed. Then Z-line deformity, it is carpometacarpal flexion. Then metacarpophalangeal hyperextension, and interphalangeal again flexion. Flexion, hyperextension, and flexion. Then this is again showing swan neck deformity, flexion at the distal interphalangeal joint. Then this is image of mallet finger. Mallet finger is basically the extensor tendon rupture. Okay, extensor tendon ruptures and the finger will be in the flexed position. And if the flexor digitorum profundus is ruptured, then the finger is known as jersey finger. See, jersey finger if the flexor digitorum profundus is ruptured. Like person was holding the jersey and the another person runs away. So the finger will be in the flexed position and this is known as jersey finger. Splint finger in the slight flexion. Okay. Then next. So these were the important images. The few images are left. We will be discussing in next session. I hope this will be helpful to you. Please do like and subscribe my channel. Thank you.